All right, hello, and thank you for joining us for this unique discussion on treatment considerations for MST survivors with PTSD. We will begin starting in just a few moments. Before we begin, I ask that you keep your mics muted and your videos off. In the event of someone interfering with the program, we will shut this link down and send out another email with the new link. If you have questions regarding CEUs, please email myself, Ashton Kroner. The email address is on the slide. We will also be sending out a recording of the training to everyone who has registered. For any technical support, please email Chris Miller. His information, again, is right below mine. If you have questions for the presenters, please use the chat function. If you look at the bottom right of your screen, you will see the chat bubble. All right. All right, so for today's agenda, we're going to be doing an introduction right now, and then from 9:10 to 10 o'clock, Dr. Vanessa Tyrone is going to be talking to us about interpersonal violence among MST survivors. From 10:05 to 10:55, we will be having a presentation by Jocelyn Kressler and Miso, and then we will have from 11 to 11:50 sexual trauma and the pelvic health by Sheila Dugan, and then if you have any questions from the 11:50 to 12 hour, we will be happy to answer all those questions. All right, so our first presenter is Dr. Vanessa Tyrone. Vanessa Tyrone is a clinical psychologist in the Department of Psychiatry at Rush University Medical Center. Tyrone completed her bachelor degree at the State University of New York College at Geneseo and her master's and doctorate at the University of Tennessee. Her internship was at the VA Western New York Healthcare System, and she completed a postdoctoral fellowship in trauma and women's behavioral health at Rush. Outside of her academic career, she has a history of advocacy with survivors of intimate partner violence and sexual assault. Tyrone specializes in providing evidence-based therapy for PTSD with particular attention to how gender and cultural identities impact individuals' experiences. Her research looks at the impact of interpersonal violence on mental and physical health, relationship functioning, and engagement in care. Welcome, Vanessa.
Thank you, Ashton. If folks can take a moment as I start the presentation here to do the poll, you should be able to view it by clicking on the chat box, which again should be in the right-hand corner of your screen. Okay, this is just some disclosure information. The activity is not being presented with any bias or commercial support of any kind. And to start us off, I wanted to explain a little bit about what the road is. For those of you that may not know, we're part of what's called the Wounded Warrior Care Network of clinics across the country that serve veterans, and each is supported by the Wounded Warrior Project, but also affiliated with a major medical center. And so we're affiliated with Rush University Medical Center in Chicago, and we specialize in treating post-traumatic stress disorder using cognitive processing therapy. Both veterans who have experienced combat and military sexual trauma. And each of us will be highlighting some data from the patients that we serve. So I wanted to give everyone a picture of what those clients look like clinically, and also kind of give you an idea if whether you might be working with any veterans who might be eligible for our programming. And then Jocelyn and Miso will speak a lot more about what the programming actually involves in their talk. But our intensive outpatient program, the main requirement is that we're able to confirm a diagnosis of post-traumatic stress disorder in a clinician-administered post-traumatic stress disorder interview that we as part of our standard intake. We also ask veterans to furnish a copy of their DD-214. And it doesn't matter how long they served for, their discharge status, their service connection, really they just need to show any kind of history of service. There are some exclusion criteria, which basically include any kind of serious medical illness that needs either inpatient care or regular daily care we wouldn't be able to accommodate for in the IOP schedule, things like needing kind of regular chemotherapy, the inability to perform activities of daily living independently, a serious kind of other psychiatric conditions. So examples would be somebody with really like active psychosis, a severe untreated eating disorder, those kinds of things. Also concerned about acute safety risks. So that would be somebody with kind of active suicidal ideation, potentially with a plan and intent to harm themselves, or a very recent hospitalization for a suicide attempt. Lack of stable housing, because we know that interferes with engagement in PTSD therapy. Very severe TBI, and an active substance use disorder where the person is either unable or unwilling to reduce their substance use. So I mentioned those exclusion criteria with the caveat that oftentimes, even for folks that may have some of these criteria at baseline, we're sometimes able to link them with case management through the Wounded Warrior Project, or kind of work with their clinician in their hometown to kind of get them ready to come to the IOP. So we end up seeing veterans who start the intake process with us. So again, just kind of things to keep in mind as each of us is presenting these different aspects of the care we provide, if you think you have veterans that might be a good fit. Oops. And we'll each also be speaking about military sexual trauma. And so I wanted to give us a shared definition to work from. So the VA defines military sexual trauma as psychological trauma resulting from a physical assault of sexual nature, battery of sexual nature, or sexual harassment, which occurred while the veteran was serving on active duty or during their training. Sexual harassment is further defined as repeated, unsolicited, verbal or physical contact of a sexual nature, which is threatening in character. And there was a meta-analysis done fairly recently in which 16% of veterans were found to have experienced MST. When a really kind of broad definition is used, so when we include both experiences of harassment and assault. And so that breaks down to just under 4% of men and 30.4% of women. And then if we look specifically at sexual assault in the military, it's about 39%, just under 2% of men and 23.6% of women. So you can see here there are some pretty drastic gender differences in the kind of prevalence of these experiences. However, given the fact that there are higher absolute numbers of men in the military, you know, that 3.9% of men is actually going to be a larger number than the 38.4% of women. All right. So again, kind of wanting us to have shared working definitions. I'll be focusing specifically on a particular type of interpersonal violence among MST survivors, intimate partner violence, or IPV. And so this can include anything from physical, emotional, or sexual harm that happens in the context of a relationship, including stalking. And it's important to mind that each of these behaviors can kind of occur on a continuum from mild to severe. And it's important because sometimes we kind of conflate the type of abuse with the severity. And so I've heard providers kind of talk about, oh, well, veteran is only experiencing verbal or emotional abuse, for example. And we know that even that type of abuse, when it is very severe, can be associated with some pretty deleterious outcomes, like severe depression symptoms and suicidality. So again, kind of keeping in mind each of these experiences can be pretty impactful. So, my slide is coming up kind of wonky here, but the idea that I wanted to kind of convey with this slide is that there are lots of different types of interpersonal violence, and we know that they can kind of all be related to each other in that having these types of experiences can predispose or put people at greater risk for having a type of these experiences, right? So for example, childhood physical and sexual abuse is associated with higher risk of physical and sexual abuse kind of later in life. Additionally, there can be kind of overlap between some of these experiences in terms of civilian sexual assault or military sexual trauma. Those may or may not actually represent experiences of intimate partner violence in and of themselves, particularly considering that the majority of intimate partner violence is enacted by somebody who is known to the survivor. Okay, so getting a little bit more into the details of IPV among veteran and service member populations. So we know that IPV is very common. 32% of women on active duty report physical violence, stalking, or sexual assault from an intimate partner. And then when we even look at kind of more recent experiences, 17 to 31% of women receiving VA services report IPV in the past year. So it's both prevalent overall, and there are decent odds that a veteran you're working with at any given point could be experiencing active IPV. IPV is also really common among veterans seeking outpatient couples therapy. And so the most prevalent tends to be verbal IPV, followed by physical and sexual abuse. And there's some evidence that suggests that IPV may be both more prevalent and more severe in military compared to civilian populations. An example here is a study that looked at OEF, OIF who are separated from their partners. And so 53% of those folks reported a history of violent conflicts with their partners, and 26% endorsed that their partners were afraid of them. There are some kind of unique cultural aspects of military service that could kind of create both this risk for greater prevalence and severity of IPV. So to start off with, within the military, most personnel, except for folks like family advocates, chaplains, and medical professionals, are required to report suspected IPV to the chain of command. And so there's some evidence that that can really increase a sense of secrecy, because folks don't want the career of the service member to be adversely impacted. And then in terms of risk factors, we know that deployment heightens risk of IPV upon service members return home. And PTSD and substance abuse are also risk factors, both for kind of perpetration actually and experience of IPV. Also, military veterans are more likely to own firearms than civilians, and specifically, female veterans are more likely to live in households with firearms that they do not own compared to female non-veterans. So that's some background on IPV in the veteran population. And we did have a bunch of respond to the poll here. So I'm going to see if I can figure out how to display this to everyone. So I actually don't know if folks can see this, but the two questions that we asked here were about how comfortable you feel kind of screening your veterans for experiences of IPV, and then how confident do you feel addressing IPV once it's been identified. And actually, it looks like we're doing pretty well here as a group. So the responses for each question kind of tended to fall between neutral and very comfortable. We didn't have a lot of folks that were in the very uncomfortable range of the spectrum. So that tells me I might be preaching to the choir a little bit here, but we'll still kind of review some guidelines for screening. When I talk about IPV, I also like to kind of talk about the idea of re-victimization. So re-victimization is kind of a broad term, but it can include experiencing any of the types of interpersonal violence we discussed before, and then having another experience of interpersonal violence kind of later in life. And it could be the same type repeatedly, or it could be different types, for example, physical versus sexual abuse. And so this kind of category can include times when somebody's had military sexual trauma and IPV, and we do see that MST increases risk for recent IPV, in particular sexual IPV. IPV is also very strongly associated with like the current severity of veterans' PTSD and depression symptoms, even when we adjust for that MST history. So it could be really important to identify these experiences in veterans so that we can like appropriately address their symptoms. And then oftentimes the patients that we work with, particularly in cognitive processing therapy, we're often working with a lot of maladaptive beliefs that people have, blaming themselves for the trauma in some kind of way. And so folks can have a lot of questions or beliefs around this idea that there must be something about me that I'm doing to cause this. There must be something that people are picking up on about me that makes me seem like a good target for these behaviors. And so it can be really helpful to educate the veterans that there's not really strong research that supports there's some kind of like distinct personality trait that tends to make people victimizable. There also isn't really strong research. The results are pretty mixed in terms of the degree to which threat perception plays a role in victimization risk. But more reliably, we find that, again, kind of mental health symptoms like severe PTSD, like severe depression, substance use disorder problems, predict victimization. And some ways to kind of explain this to folks are that, you know, educating them on a basic level of what PTSD and depression symptoms are. So if we think about things like low motivation, poor concentration, poor self-esteem, cognitive changes, right, where we can get a picture of somebody who might be experiencing IPV and might be telling themselves things like, I guess I just deserve this, or this is my fault, or I don't have the power to do anything about this. And then some of those other symptoms could make it very hard for them to act detect, even if they did, if they were able to kind of see that it was a problem. And then in terms of things like substance use and dissociation, those could be kind of strategies that folks developed sort of adaptively to survive certain instances of abuse. However, it could again kind of make them more vulnerable later on because it puts them less in control in interactions with their partner if they're dissociating or under the influence of substances. So the part that can be really kind of empowering to patients is that if we're talking about kind of symptoms or behaviors, those are things we know how to address or change compared to it being, again, kind of something about their personality or something about them. So potentially a useful idea clinically. And in terms of identifying that IPV in the first place, there are a few characteristics that we know really important when we're conducting screening. So those include having a screener that is comprehensive, meaning if we know what we're trying to assess, so in this case IPV consists of verbal, physical, sexual abuse, we want a screener that kind of captures the range of those behaviors. We want it to be behaviorally specific, meaning we want to describe in kind of objective terms the behavior we're trying to assess and avoid the use of terms like rape or abuse that could be very kind of stigmatizing or value laden. For example, someone could be with a partner who's sexually assaulting them, right? They may still care about that partner, and they may not think about partner as a rapist, or they might not think about themselves as a rape survivor, even if they're experiencing behaviors that we might categorize as being consistent with rape. So I go over these rules kind of generally because there are a lot of different screeners out there. And if you're not in an institution that like requires the use of a screener, you may want to kind of reword how you ask the questions so they sound a little bit more conversational and not so much like you're going through a checklist. But you want to make sure you kind of have each of these criteria. The last one is fairly self-explanatory, but we also need these assessments to be confidential in order for them to be accurate. So in kind of in-person settings, that would typically involve things like if the patient has brought someone with them to visit, asking them to leave the room. And there's kind of a different layer of this now that we're seeing a lot of patients via telehealth, right? It's kind of asking people to be in a private location when they're doing the call. And sometimes I've been working with patients who like say they're in a private place when we start the call, but then I hear things kind of like conversations happening in the background or someone kind of popping in and out of the screen, and that might be a cue to me to either kind of again ask that they can be somewhere more private, or in my mind I'm going to hold back on some of these questions knowing that they may not answer them fully with the other people around, and I might try to work them in kind of in the next conversation with the veteran. So this screener here is called the E-HITS. It is used in many kind of VA settings, and so it's just one example of many screeners out there. Over the past 12 months, how often did your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you, or force you to have sexual activities? And so for this particular screen, you provide the response scale below, and any response equal to or greater than 7 is considered a positive screen for IPV. I also have this other assessment tool here. I apologize if the text is a bit small, But this is called the danger assessment. And so this is considered kind of a secondary assessment in cases where IPV is identified, but then we kind of want to try to gauge the severity or the risk level of what that person is experiencing. There are some VA sites that have actually implemented a version of this as part of their IPV screening protocols. Even if you don't kind of use this screen again in a super formal way, it gives us an idea of kind of what to look for in gauging that risk level. And so how this was developed is actually kind of interesting. The researchers took a bunch of IPV survivors that were referred by police officers. These are folks already probably experiencing the more severe end of the spectrum of IPV. They assessed them for what types of abuse they were experiencing around that time, and then they assessed them again 6 months later to see whether they had another serious incident of violence. And so these items are based on the behaviors that at time one were the most predictive of experiencing serious violence later. And so they include things like having an increase in the frequency or severity of the violence over the past year, a partner using a weapon or threatening to use a weapon against a person, the person having this kind of subjective fear that their partner might be able to kill them. And one that was associated with really high risk odds was any kind of choking or strangulation. It also asks if your partner or ex, because sometimes violence continues even after a person kind of attempts to end the relationship, is very extremely kind of jealous. And again, so the idea is this gives you, if any of these kind of show up as you're asking the person to actually describe what the IPV has been like, these are kind of red flags for your patient's risk level. Another neat thing that kind of accompanies this tool, in case any folks on the call are involved in kind of training medical personnel where you might work, they also have a strangulation protocol, which medical providers in places like ER, primary care can use to address any like physical or neurological symptoms that an IPV survivor might be having secondary to strangulation. And another thing that we kind of train the clinicians in our clinic once IPV has been identified is to try to match whatever intervention they're doing with the stage of change that the veteran might be in. And so just like a quick review, I'm sure many folks are kind of familiar with the stages of change. These are used to understand like different potential behavioral changes, things like smoking cessation or diabetes management. And can also apply to IV. So pre-contemplation stage is when the individual kind of isn't really aware, isn't really acknowledging that there's an issue. Contemplation is the individual knows a problem exists, but they haven't necessarily committed to taking any action to addressing it. Preparation is when somebody's kind of getting ready to change. Action is when they've put steps into place. And maintenance is after they've already kind of made some change, figuring out like how to keep that going. The termination line there is blank because there's some debate as to whether there really is ever kind of like an end stage for a lot of behavior change or whether we're always experiencing some degree of maintenance. And these are often like presented in linear fashion, but also keeping in mind that an individual can kind of move between the stages. For example, they may try to take action that could go really badly, and then they could kind of move backwards to contemplation again. And here I have kind of a case example based on some real patients that we've seen in our clinic. And I'd like everybody to take a couple minutes to read this here. So you're presented with the demographic information, kind of what the patient describes as a presenting problem, and then some information about how the patient responded to IPV screening. And so I'd like you to kind of think about essentially kind of what stage of change you think this patient might be in. And based on that, kind of what types of intervention might be appropriate. And we'll give everybody just a couple minutes to read this over. And there's a question in the chat, should you be answering what stage of change she's in? Yeah, you're free to kind of put that in the chat. I won't necessarily be like kind of calling on people, or you can just kind of note it for yourself. Okay, so in my estimation, I would probably put this patient in either kind of the pre-contemplation or the contemplation stage. You know, on the one hand, she kind of mentions that she plans to kick out her partner eventually, right? So that kind of gives us a clue that there's something wrong. However, on the other hand, she also talks about her partner as being like her primary source of support. So there could definitely be some like ambivalence there about acknowledging that there's a problem in the relationship. And you know, the patient here is really focused on like getting into our IOP, right? She's saying, I want like the PTSD treatment. I really think that's like my last chance, right? So our goal as the providers would be to kind of do anything we can to get her ready into the treatment. Based on our exclusion criteria, it could involve things like decreasing her substance use, for example, to kind of get her ready to be eligible. And the hope would be, again, if we can address the PTSD, that might give us kind of a foot in the door in terms of building trust with the patient. And in the meantime, it could leave us some room to kind of build on that ambivalence that she's experiencing about the relationship. That's always going to be the goal when people are kind of pre-action stage, is building that ambivalence or getting them to kind of speak in their own words about what's not working for them with the relationship, or how that relationship might be inconsistent with like their values or their goals. A couple other things to kind of highlight from this case example is that the veteran on their own disclosed all these experiences of more remote interpersonal trauma. And it's important kind of when we're working with patients, when patients kind of voluntarily disclose some of those experiences, we can't assume that because they didn't bring it up on their own, they're not experiencing IPV. We still want to screen. It could be harder to bring up with a provider that your current partner is harming you than it might be to bring up an experience from the remote past. I've also seen in some like medical training materials, like geared towards other types of providers, they encourage providers to ask questions like, do you feel safe at home? And that that question might not fly with a lot of our veterans, right? Because even if someone's experiencing IPV, they might still consider themselves to be like very strong and very capable, and able to protect themselves. And so they could answer yes to that question, I feel safe, and still be experiencing some of these kind of IPV behaviors. Someone also mentioned in the chat kind of this idea of stabilization before trauma processing. We're going to touch on that a bunch, I think, through a couple of the different talks here. Okay. Now, on the other hand, if you have a veteran who is a little bit more like ready for change, they want to make some action, maybe separate from their partner, maybe they need to get somewhere safe that day. The two main resources that I recommend for veterans are the National Domestic Violence Hotline. And it's not just a hotline, there's actually like a website that has a ton of resources on it. It also has a chat feature where folks can chat directly with support. And the thing that's great about this is you do not have to be an expert on all the IPV resources like in your hometown. This is a federally funded national network. So no matter where you are, any veteran you have call the hotline, they can link them with legal advocacy organizations that will foster their pets need to get out of the house, pets at home with an abuser, like basically kind of anything you can imagine. So that really is the go-to. This is a little bit of a typo here that this is repeated, but then the other really important resource is the Directory of Intimate Partner Violence Assistance Program Coordinators. It's kind of a mouthful, but if you go to this URL here, it should also come up if you just Google VA IPV coordinators. It gives you a directory, again, kind of nationwide, and it'll tell you in any VISN who's the point person for PV and their contact information. A thing to keep in mind with this is that these folks aren't necessarily going to kind of leave a voicemail with veterans or anything like that who they haven't spoken with before, because they don't know if kind of leaving a message could make them unsafe. So, it's important to know to speak with a veteran about like whether it's we should tell them it's okay to leave a message or not, that kind of thing. But they specialize in working with veterans and family members of veterans who may be perpetrating or experiencing violence in any capacity. So in addition to being able to link folks with resources such as shelters, right, they can also kind of link people who have trouble using aggression with resources like the Strength at Home group, which is a trauma-informed cognitive behavioral intervention. It's being offered virtually in a lot of places now, geared towards reducing aggression use. This is typically also kind of where I talk about the idea of kind of mandated reporting a bit. It's really important to familiarize yourself with your laws in your state, because it can vary a bit. But in most of the places where I've practiced, really generally, right, we need to report abuse of elderly individuals, minors, or people with, severe disabilities. However, violence that one adult kind of perpetrates towards another adult typically isn't reason to break confidentiality. A way to think about it is that the HIPAA laws kind of trump any desire to break the confidentiality there. In many cases, it could be that breaking the confidentiality, informing the police of an IPV situation, could actually make the patient or unsafe, because the abuser learns that our person has been talking to people about what's going on. That could kind of trigger retaliation. Now in Illinois and Chicago, there are actually laws that mandate medical professionals to report when a violent crime has occurred. Okay, but even in those cases, the Chicago police kind of go around and they educate hospitals and they explain, yeah, you need to tell us if somebody's been stabbed or somebody's been shot, but there's no kind of rule set on how quickly you need to tell us that. or that you need to tell us the person's identity, right? So providers can have a conversation with a patient in the ER and ask, do you want to speak to the police? If they say no, they can coach the patient, hey, the police are going to come, you don't need to talk to them, or they can call the police after the patient has left, versus they can kind of facilitate the conversation if the patient is interested. Another really kind of common concern is whether or not there are children in the home. I have a colleague that I like how she explains it. She talks about there being kind of a 10-foot rule. And so if a patient kind of describes violence happening and it seems like the child is in very close vicinity, that's going to make her more likely to report. And yet it's always going to be a gray area. So she gives us one example of she had two veterans where they were kind of on one side of the apartment, the kids were kind of on the other side of the apartment, and each of the veterans pulled out a gun and aimed them at each other, right? And so in that case, the kids were beyond the 10-foot rule, but there were firearms, being kind of brandished in the apartment. And so she did call and report that. So it has to be kind of a judgment call, weighing often like kind of the relative risk and the risk of reporting, I guess, and the risk of not reporting. Okay. So I want to talk a little bit about the research data specifically pertaining to IPV and cognitive processing therapy treatment. So there were a couple studies done by Iverson and colleagues, both published in 2011 with the same sample. And those did show that women who were experiencing IPV in the 6 months prior to treatment were less likely than non-victims or folks that had a history in their more remote past to actually start the CPT. However, among people who did start the CPT, folks with recent IPV were not less likely to finish the treatment. So as long as we could get them started, they would complete it. And the more frequent the IPV was towards the beginning of treatment, the greater symptom reductions that they actually experienced in cognitive processing therapy. Also, there was another set of analyses that showed that the more women's PTSD symptoms decreased over treatment, the less likely they were to experience physical IPV in the 6 months after treatment. So not only are folks with recent IPV able to engage in trauma processing therapy and benefit a good deal from it, it may also decrease their risk for ongoing IPV. In other words, it could also be a safety intervention. And so also another study that we did, this wasn't focused specifically on sexual assault occurring in the context of a relationship, but we separated out patients with a history of one sexual assault from patients who had histories of multiple sexual assaults. And we looked at kind of their data pre-treatment and throughout treatment. This chart here demonstrates their PCL survey results, and they're given those every couple of days during their treatment. And so again, the folks with kind of multiple sexual victimizations were more distressed in terms of depression, PTSD, anxiety, at the beginning of treatment, but they were also equally as likely to kind of benefit from the treatment. So kind of to conclude, I want to think about these ideas. I know in the recent kind of history of the VA, there's been really big prioritization of Mst screening. We do still want to identify that for patients, obviously in terms of their treatment and linking them with resources. However, like if we have kind of limited time to work with a patient, screen a patient, we really want to make sure we're addressing kind of more recent IPV, because it really could be linked to their mental health symptoms and kind of safety needs. Once we identify IPV, we want to consider the severity and try to match what we're doing with the patient to their stage of change. And then I think taken together, some of the data from our sample and the data done in other collected in other CPT samples suggests that this idea that multiple experiences of interpersonal violence across a lifespan, or sometimes it's referred to by folks as kind of complex trauma, does not necessarily mean that folks are inappropriate for a trauma-focused treatment, or that we should delay that treatment, because they can still experience significant reductions in their symptoms, and it could help them be more safe. So I think, do we have a couple minutes for questions before we do the next talk?
Yes, we do, Vanessa, and we do have one. If you could explain the policy in regards to mandated reporting in the military between unrestricted and restricted.
Oh, that's a really great question. So this, like, I'm not claiming to be like kind of a foremost expert on this, but my understanding is that kind of the goal of restricted reporting is basically that's when an individual wants to basically document that this happened, and it could be beneficial to them later in terms of their attempts to seek service connection and whatnot, but they're saying that they do not want to pursue any kind of charges against the individual. And so, in a way, I've heard that that also kind of binds the veteran to not, they can't disclose this to the experience really to other people. Um, the goal of kind of unrestricted reporting is that, that's when they want to leave the door open to, actually pursue charges within the military justice system. And so, unfortunately, even though I think there are still supposed to be safeguards to the veterans' privacy in that scenario, many of the veterans I've worked with who've pursued some degree of unrestricted reporting talked about how a lot of people kind of within their unit ended up like knowing about the experience. Folks face retaliation sometimes. I've even had patients talk about people kind of coming to them and threatening them to kind of try to pressure them to drop the charges. And so there can be like definitely some secondary traumatization that happens there. But also I think some of the nuances of how they're handled may differ a bit like from branch to branch as well. Folks kind of have like slightly different protocols. Yeah, and there's a comment here about, again, kind of stabilization for trauma processing. So again, I would say our data argues that we don't necessarily have empirical evidence that's the case, even though it's been kind of, I think, taught for a long time among folks that specialize in treating trauma. And I think Jocelyn and Miso's data will speak to this a little bit as well. Okay, if there are no other questions on this section, we can also take any kind of circling back later. I think I'll kind of stop sharing my screen so that Jocelyn and Miso can share theirs.
Thank you so much, Vanessa. So if you have any questions, please put them in the chat. We will be able to circle back, just like Dr. Tyrone said, at the end of the programming. Also, just as a reminder to help with the kind of the connectivity, if everybody could that is not presenting, go ahead and mute yourself and then shut your video feed off. We greatly appreciate it. All right, so the next session is Delivery and Impact of CPT through a Mass Model, being presented by Dr. Jocelyn Kressler and licensed social worker Miso Bosar. Dr. Jocelyn Ariana Kressler is a postdoctoral fellow at the Road Home program. She graduated from Adler University in Chicago, Illinois, and specialized in both traumatic stress psychology and substance abuse counseling. Jocelyn completed her pre-doctoral internship at the Jesse Brown VA Medical Center and has prior experience serving clients with complex clinical presentations in hospital, outpatient, and community mental health settings. Jocelyn's clinical training has focused on delivering empirically supported treatment for substance abuse and trauma-related disorders. Jocelyn's research has focused on the interconnected relationship between PTSD and addiction, its impact on both the individual and the family, and how integrated approaches can effectively treat both diagnoses. Jocelyn's clinical interests include working with survivors of sexual violence, treating co-occurring PTSD, and substance abuse and program development. Jocelyn's father served 3 tours with MACV Special Ops during the Vietnam War. Her grandfather served as a flight surgeon in the Pacific with the U.S. Marines during the World War II. Miso Bosard received her undergraduate degree in comparative human development from the University of Chicago and her master's degree in social work from the University of Chicago School of Social Service Administration. She completed her Fulbright Fellowship in Ghana due to her vested interest in the sexual and mental health of minority women, particularly those from low-income backgrounds. Before coming to the Road Home program, Miso worked within the VA system as a clinician treating veterans with PTSD. She is thrilled to continue to work with veterans, especially those with intersectional identities in the treatment of trauma and comorbid disorders. Welcome.
Ashton, thank you so much. And thank you everyone who is here on the call. Hi, I'm Miso, and my colleague Jocelyn and I are going to be walking you through our portion of the presentation. Jocelyn, before I sort of jump in, do you want to say hello?
Hi, everyone. We're happy to have you. Yeah, and if you have any questions about our presentation or any of them, feel free to just put them in the chat.
Wonderful. Thanks, Jocelyn. So our portion of the presentation is really to give you a very specific and detailed picture of what we provide at the Road Home program in terms of the intervention we're providing, the evidence behind the intervention we're providing, and also why we've chosen to implement specific adaptations to traditional outpatient CPT and how those adaptations are beneficial for the population we're interested in today, which would be veteran survivors of MST. So here is the agenda that expands upon and breaks down sort of exactly the spiel I just gave you. So we want to sort of convince you from the get-go that the intervention that Vanessa so eloquently described in her presentation is effective, so CPT. We're going to give you sort of a brief overview of what the literature says about what we know about the effectiveness of CPT. We'll talk about sort of research that describes different ways in which CPT has been implemented, sort of the different adaptations that have already been done out there. And then we'll also talk about why at Road Home we've chosen to select and implement a very particular type of adaptation of CPT in order to have really good results for veteran populations, particularly MST survivors. And then we're going to sort of give you a breakdown of what our program looks like in terms of, okay, so now you've convinced us, Miso and Jocelyn, that this adaptation works and it's really great for our veterans. So what does that actually look like? Give us a sort of relay of things, right? And then at the very end, we'll sort of talk about specifically, because we serve 2 cohorts of folks, those who have a history of combat trauma and those who have a history of MST. So we'll talk about specifically the adaptations that Road Home has implemented in our program and just in our training of clinicians for, okay, so how do you do this particularly well for folks who are coming through our program who have a background of military sexual trauma specifically relative to like combat trauma. And I have a tendency to talk fast, so if you need me to repeat, just shout or put something in the chat. Okay, great. Next slide, please. Okay, so here is sort of where we'll start. We'll sort of start with what the CPT protocol entails. This is probably review for a lot of folks. Still, we do want to spend a little bit of time reviewing it. Just like Vanessa talked about really briefly in her portion of things, it's a very sort of cognitively oriented protocol. It is quite similar to CBT in a lot of ways, but it is absolutely trauma specific. So it zooms in on sort of counteracting avoidance, which is super common and one of the symptom types that we see in folks who have PTSD, to actively go against that, to spotlight maladaptive traumatic cognitions, to like bring them to the forefront, get folks to really be able to identify what we call stuck points, and then to challenge them to figure out sort of based on the evidence, what are more accurate, balanced, flexible beliefs once they sort of take a step back and sort of process fully what happened to them and what they're telling themselves about why things happened. That's all I'm going to say about that. Okay. There is a lot of evidence out there, and again, this is probably review about the effectiveness of CPT as an intervention. For this particular slide, I'm really going off of like a meta-analysis that was done that sort of did a lot of the work for me in terms of combing through from the beginning when this intervention was sort of rolled out, sort of what folks have to say in general now that we've, you know, tested out CPT in all different sorts of ways. So there's a lot of studies out there where they test out CPT in both veteran populations and non-veteran populations, for one. They also have studies out there where they're testing CPT in terms of the number of sessions, but we'll sort of touch on that a little bit later. So the meta-analysis essentially tells us that CPT is a very effective intervention, as effective as other sort of evidence-based treatments for trauma, such as prolonged exposure therapy. But what also this slide highlights is that it is also like more effective when you sort of break down the intervention as a whole. So CPT as a whole has like the cognitive restructuring elements of the protocol. It also has an element where folks can be asked to do like a written trauma account. There was a study that was sort of curious about what is like the special sauce or the magic sauce of CPT. If we just separate out the cognitive restructuring elements and sort of compare that to the efficacy of just asking folks to do like a written trauma account, does it still work? And they found that yes, it absolutely does. So essentially, if you so choose and your client chooses to opt out of doing a trauma account for whatever reason, maybe there's like a time issue, like research shows that that is like just as effective as long as you stick with sort of like the special sauce of CPT, which would primarily be the cognitive restructuring elements of the protocol. Overall, the meta-analysis suggests that compared to sort of other active treatments, not necessarily evidence-based trauma treatments, but just like active treatments, folks do like significantly well versus the control group, and the results sustain at different amounts of follow-up. I think there was a question, but I'll look at it in a second. Oh, and another thing that's really great about the research that we have on CPT is it suggests that not only do we often see reductions in PTSD symptomology, but we also sort of see a lot of times reductions in non-PTSD specific symptoms, primarily depression. There's a little bit of mixed results out there as to whether or not there's a gender-based effect. Some studies seem to say that actually like women veterans in particular seem to show an increase of like symptom reduction post-treatment, but there are some other studies to suggest that maybe that gender-based effect isn't quite so, like isn't quite something that we can say like with certainty. There's sort of mixed results around that. Let me take a second to look at the question. Oh, yes, it's the trauma narrative. It's, yeah, hopefully I answered that question. Okay. Yes, please, could you go to the next slide? Wonderful. So this slide is really expanding a little bit on the previous slide that I talked about. Again, there are sort of mixed studies to suggest, okay, there's sort of mixed results around whether the elevation of someone's PTSD symptoms prior to starting CPT impacts sort of the amount of symptom decrease that we see. Some studies say, yes, folks who have less elevated symptoms at outset seem to show greater increase in symptom reduction. And other studies seem to suggest that no, folks who have sort of subthreshold PTSD versus folks who have threshold PTSD, they both see pretty similar and comparable symptom reduction results. So there's sort of mixed results around that, but we wanted to sort of touch on that. The other point here that's really important is sort of the last bullet point on this slide, which is the sort of traditional way in which CPT was developed and the way that it's been tested the most is in its 3-month model. So it's like a weekly treatment, 1-hour sessions per week that's sort of done over 3 months. However, there are some great studies out there that have sort of tweaked that particular aspect of CPT, and they provided CPT on a different timeline. So there's this great study that came out where they were providing CPT over a period of 30 days, as opposed to the traditional weekly over 3-month model. And those results seem to suggest that, yes, it's as effective and it can be implemented in sort of what they call like a MAST model. So I want you to sort of hold that thought that I just said in terms of this idea that traditionally this is how CPT was developed. There is some evidence out there to suggest that even with some like timeline adaptations, it can be really effective, because that's going to be really important for like the duration of our presentation today. But I also want to take a little bit of time to switch gears just a little bit, because we're all here because we're passionate and interested in learning more about how to use CPT interventions for a very particular and beloved population, which would be our, veterans who have experienced a sexual trauma in a military context. So something that's awesome about CPT as an intervention, it was originally developed for sexual assault survivors. Obviously, there have been lots of studies to show that it is an effective intervention for folks who may have other trauma types as well. And it's still really special that it was originally developed for sexual assault survivors. And there's even some research to suggest that like CBT-based protocols, so prolonged exposure therapy and cognitive processing therapy, those are sort of the interventions that have sort of the most robust results around, okay, this works particularly well for those who have PTSD secondary to any kind of sexual assault related trauma. So that's sort of like the double green light for us in terms of using this protocol for this population. There are lots of studies to support that. Those are some other studies on that. There are RCTs and randomized controlled trials and non-randomized controlled trials to sort of provide evidence for that. The other thing that's, I think, pretty special about CPT as a protocol is in studies that look at CPT being provided for veteran survivors of military sexual trauma, we not only see decrease in sort of mental health symptoms, but we also see improvements in associated physical health problems as well, which has sort of opened up this conversation of what, a lot of us know and hold to be true, which is there's such a connection between all the types of health. And they're really, there is a difference, but also a lot of overlap between mental and physical health. And so this can sort of be really exciting when we think of just providing treatments that do have holistic gains for military sexual trauma survivors. Yeah, next slide. Okay. So why did I want you to sort of hold on to what I mentioned 2 slides ago, which is, CPT stands for cognitive processing therapy. That's the intervention that we're sort of trying to sell you on during our portion of the presentation. Thank you for asking me to clarify that. I'm going to try to use less acronyms now. Okay. So why did I want you to sort of hold on to this idea that, okay, you could, give this intervention in this traditional sort of timeline over 3 months. There's some research that shows that you can adapt the timeline of the intervention, for example, over a period of 30 days, and it works. But why is that so important? Here is why. At the core, I think all of us have this goal of wanting those who need this treatment to be able to get it because we care so much about this population. There's so much great evidence that, thank you, Vanessa. There's so much great evidence that CPT works and it works so well. But even something so great with a lot of evidence behind it, we won't be able to sort of make the most out of its effectiveness if the folks who need it most aren't able to get it in the dosage that they need to sort of reap the results. CPT is a great intervention, and there's a lot of attrition in this intervention being rolled out. There are a lot of folks who get lost to treatment during treatment, even if the motivation for treatment might be there. There's like studies show, it's right here on the slide, like almost half, end up dropping out at some point in like the 13 to 15 session protocol. In the veteran population, 30 to 62% dropout in the civilian population. It's a tough protocol, and a lot of folks are lost. And we're sort of witnessing, I think, like a gap that we could really be meeting and fulfilling if we can just figure out how to sort of get folks the treatment that they're needing and wanting, but sort of also attending to some of those barriers. And something that we found through research at Road Home is that one way that we can sort of attend to this attrition rate is by utilizing the MAST model. So instead of providing CPT sort of drawn out in a traditional 3-month model, if we can make it sort of on a more like manageable timeline for folks, then we can really and effectively resolve this attrition problem and get effective results in symptom reduction comparable to what we would see just on like the traditional timeline that has the most sort of research behind it saying that this works in this form. So yes. Oh, and as an aside, this is also in your slide deck in terms of if folks are interested in learning for themselves or getting trained in CPT. But yeah, so that's just included for your reference.
Okay. So just like one thing about this, these are different CPT training sites that are totally reputable, that you're able, some are self-learned, some are like web-based, some are in person. So there's a ton of different options. But all the individuals that work at Road Home as clinicians, we're all like officially certified having certified training in CPT. And so that's also something that's potentially available to you as well. So looking at these things will kind of lead you in those directions. All right, so let's talk a bit about the MAST model for CPT. So one thing to just kind of note, most of the information, most of the research, and most of the years that we've been at Road Home have been with this 3-week intensive outpatient treatment model, otherwise known as an IOP, intensive outpatient program. When COVID hit, after kind of having to pause, we did reintroduce the program, but we did it in a 2-week model. I will get to that to kind of explain how that's a bit different, but just kind of to let y'all know. So with our 3-week intensive treatment program, we're talking about 3 weeks, 14 treatment days from 8 to 5, including daily individual cognitive processing therapy, CPT, group cognitive processing therapy. Also kind of Road Home really prides itself on wanting to treat individuals from a holistic standpoint. So including yoga, including mindfulness-based stress reduction, also daily psychoeducation, and case management. Okay. So in terms of our intensive outpatient program, when it was the 3-week, we would have two different tracks. We had a combat trauma related track and then a military sexual trauma treatment track. Our military sexual trauma treatment is actually the only intensive outpatient program in the country that is for MST only. So there are VA outpatient or VA inpatient that focus only on MST, but we're the only one that has the IOP for it. Probably should let you know. So we usually run 2 cohorts concurrently. They will be mixed gender, mixed gender identified, and 12 veterans per cohort. We also, in the third week of our programming, involve family members. That it was an in-person. So this is just a small graphic that really shows where all of the different veterans that have come to our program are coming from. So really, we're serving individuals from across the country, um, and now even in Mexico. So we're talking about over 500 veterans, and this is since 2016. So we've had to make some COVID-related adjustments to our IOP. Our treatment length has gone from 3 weeks to 2 weeks. Our family programming is now a 2-day virtual programming that is primarily entirely psychoeducation based, just kind of helping loved ones understand what is cognitive processing therapy, what are their loved ones doing, in terms of what are the different groups that we offer. We also no longer have the CPT group, and instead we've kind of incorporated additional groups such as a sleep hygiene group, cognitive health group. We have an emotion and communication skills group. We also have a CPT group to kind of reinforce skills learned in the session, but that's different than a normal CPT group. And we also have removed the nutritional psycho ed group at this time, but we'll be reintroducing it soon. So there's a ton of empirical support for this 3-week IOP program. It's shown that not only PTSD, but also depression-related symptoms not only have reductions, but maintain them after a 12-month follow-up. There are symptom increases at 3 months post-treatment, but they're very minimal. And these gains that we're noticing in this 3-week model, and even this 2-week model, are really comparable to that 3-month protocol where it's 1 hour once a week. We also found that the effect sizes were medium to large for MST-focused cohorts, and then also large to very large in our combat cohorts. So we're noticing that it's working for different types and different forms of trauma. And this is just a visual that shows the average symptom improvement during that 3-week protocol for y'all to kind of look at as well. But as you're noticing, as we're getting through different cohorts, we're noticing these improvements get more and more, higher and higher improvements. Okay, so this is also the long-term outcomes that I had kind of made a nod to before. Were so I'll keep going, but also symptom improvements that are really lasting for not only PTSD related symptoms, but also depression related symptoms. Another visual, because we all love visuals. Also the long-term, another just kind of final aspect about the long-term outcomes shows that changes in our negative post-trauma cognition, so those thoughts we have related to the trauma, the amount of change actually predicted those reduced PTSD symptoms at follow-up. So really what Miso was referring to before about the bread and butter, the magic sauce that is CPT with the cognitive restructuring. That's really going to dictate what those long-term outcomes look like. Yeah. Okay, so from this study, which is still under review because it's so recent from Held et al., we're finding that veterans are maintaining those treatment gains up to 12 months following the intensive treatment program, ITP, and we're actually only looking up until 12 months. So it could be longer, but as of now, we're kind of looking at the 3-month, 6-month, 1-year marks. Also, the majority of veterans are following the aftercare recommendations. In an intensive outpatient program where they're only here for 3 weeks or maybe even 2, it's really important from the get that we are discussing aftercare plans to make sure that they are set up for success when they leave our program and return home. And so we take we talk to them about different kinds of aftercare options, not only for mental health, but maybe physical health, acupuncture, whatever they might need, case management. And so even without potential aftercare, even though that's a strong focus, we still are noticing those treatment gains. Also kind of talking about the changes in negative post-trauma thoughts. And the other aspect to just kind of highlight is that there are greater symptom reductions and lower symptom severities, which at the endpoint, which can predict that symptom worsening. So it's really important to really notice where are we at, what are our gains throughout, in terms of understanding the potential long-term outcomes. Okay, so how do we continue to improve care? Because like, great, we're getting some awesome research and awesome returns and gains, but we want to continue to refine this process as we continue through Road Home. And so what we're finding is that new research that we're starting to conduct and look into is trying to figure out what are the different factors that impact and might predict the likelihood of an individual benefiting from a 3-week intensive outpatient program. So that's something that we're working on in preparation. We're not, finished with that yet, but at Road Home, we're really trying to continue to be ahead of the curve and keep up with our veterans' needs. Okay, so we talked about this 3-week model. We talked about kind of how things adjust a bit for the 2-week model that we've been doing. Another one that we want to really talk about is this single week. The single week one, I think actually can be the most helpful for providers that are not in an intensive outpatient program, because this is something that can be done potentially in private practice, in group practices. So delivering CPT in a single week program or a single week kind of concept would require that the client has sufficient time in their week so that they can still attain work and family obligations. So this allows them to be able to do that. It also needs to be feasible for therapists, given their other clinical responsibilities. The last part is that it really needs to be made to be as easy as possible for clinicians already trained in CPT to adopt. All right, so our current kind of look for how this 1 week is structured is an individual has 2 hour-long sessions of cognitive processing therapy a day for 5 days. So we're talking 10 sessions of CPT, and then there's an hour-long break in between the 2 sessions for them to breathe and actually take a break, but also for them to complete the assignments. And then in the evenings, right between their second session of the day and the first session of the next day, they also are going to complete additional homework assignments. So I'm not going to go through all of this, but there are slight adjustments to the CPT protocol that we've made to be able to adapt to a 1 week program. The biggest things are really, instead of going through each module of the different themes related to over accommodations and those kind of stuck points, we provide all of the modules in session 7 for the veteran to review and read at home for homework, and really to identify the stuck points from these different themes that are impacting them most. And so the ones related to these themes, right? In session, we do give priority to the assimilated stuck points. Great question, James. I will get to that in just a second. So priority during all sessions really is given to these assimilated stuck points, these understandings of the shoulda, woulda, couldas related to an index event. They're really kind of the past focused cognitions, the conclusions that we've drawn. And then once those are sufficiently addressed, there's actually an opportunity to transition to other distressing traumas and start to kind of get at those stuck points as well. Any over-accommodated stuck points, which are the cognitions about how we need to live our life now, in the present and in the future, based on that index trauma, those are addressed in session, time permitting, and also are given as part of homework. In addition to this, there are daily PCL, PHQ-9 self-assessments to kind of assess the symptoms of PTSD and depression respectively. One thing that we really did notice is that we found a similar symptom reduction in the 1 week CPT as we did the 3 week. So what we're noticing is this trend of a 3-month CPT is giving us similar symptom reduction as a 3 week IOP as a 1 week IOP. And so this idea of condensing the treatment is going to be super helpful in reducing attrition, maintaining those gains, and really effective for our veterans' lives. Okay. So these are some of the visuals, some of the graphs associated with delivering CPT in a single week and kind of what we're noticing in up to not only from the intake before they come to a program, but also 2 months out of what their PCL, which are their PTSD symptom severity, and their PHQ-9, their depression symptom severity, how those are changing. All right, so the CPT MAST model for survivors of MST. MAST really just means, exactly, thank you, Vanessa, the same amount of treatment in a shorter period of time. So when kind of thinking about the clinical considerations specifically for survivors of military sexual trauma, we really want to understand whether there's a bit of a difference. So one thing that we're noticing, and one thing to just kind of note off the bat, is that there are higher rates of interpersonal trauma within MST survivors compared to combat trauma veterans. There's also a higher likelihood that with MST survivors, they're more likely to have experienced cumulative traumatic experiences. We also know that there is a treatment gap between the MST cohort and the combat trauma cohorts. So one consideration that we're kind of taking into mind is augmenting the trauma-focused treatment and adding to it present-focused coping skills and staff sensitivity training on how to adapt treatment to survivors of MST, but also the impact that MST can have on an individual. Also, some evidence suggests that PTSD secondary to MST is more severe and then also less responsive to treatment than PTSD resulting from other forms of trauma. One thing to note, I'm going to finish this slide and then I will get to that question. So one thing to note is with male survivors of MST, one kind of question that can be helpful to ask and that we often encounter is related to how an individual's experience of sexual assault, what that means in terms of their understanding of masculinity and their sexual identity. And this is regardless of sexual orientation. Also for healthcare providers caring for LGBT veteran service members, VSM, but LGBT veterans, it's also really important to stay informed on LGBT culture related to the military experience and to prevent the perpetuation of the harmful consequences of heterosexism, of cisgenderism, and other sexual minority-based discrimination. I'm going to pass this over to Miso to kind of talk about how we can improve outcomes for MST survivors.
Great. Thanks, Jocelyn. A question that folks might be having is why sort of spend additional time at this point in our presentation to talk specifically about providing CPT in a very different timeline, like in the question that James asked, like what does a mass model mean? It just, and I think Vanessa answered in the chat, but just for everyone to hear, like providing this traditional 3-month intervention on a very different timeline, but still making sure that we're very confident that we're providing like the core parts of the intervention and we're absolutely retaining that. And so that is sort of what the mass model means. We are sort of making a very key adaptation that may sort of raise questions of, are we sort of watering down the intervention anyway? But with the evidence that we're seeing in terms of what makes CPT so effective, we're absolutely retaining those elements, and we're also seeing those symptom gains. So we can say with, you know, a strong level of confidence that it's a successful mass model. So the reason why we're spending a little bit more time talking about CPT as a mass model for veterans who have experienced MST in particular is we as a clinic have absolutely noticed that there is a difference in terms of the like experiences of PTSD for folks across the board. There's a difference in how PTSD shows up for people based on a lot of different things, even between folks who have a military background and those who don't. Even those for whom all share a military background, we often see differences in how PTSD is experienced based on, you know, all different types of aspects. Maybe it has to do with your gender identity. Perhaps it has to do with your time of service. But the other thing that we really have noticed is there is a pretty big qualitative difference that our clients are reporting to us in terms of what it's like for them to have experienced trauma that has caused PTSD based on the trauma type. And so that's sort of why we want to spend time paying special tailored attention to what are some things we need to keep in mind when we're talking about providing this sort of standardized evidence-based gold standard treatment for a population who not only has a military background, right? So it's different from like civilian population, but on top of that has a very specific type of trauma that is still connected to their military experience, but is also like very specifically interpersonal violence based. And some of the things that we noticed when we were rolling out our sort of 3-week mass model program and doing all the, you know, research studies on it to sort of see what's the data showing us, we saw initially some differences in the amount of symptom gain that was happening based on our cohort. So Jocelyn mentioned earlier that Road Home traditionally has had 2 tracks. What she meant by that is folks either come in for a combat trauma specific intensive outpatient program. So everyone in their 12 veteran cohort is there because they have PTSD secondary to a combat trauma. That's our cohort, that's mixed gender, but everyone there has the same trauma type. Versus we have a completely different track. So 3-week speed by or 2-week speed by now. And we're inviting a totally different group of 12 veterans to our program who now have a very different trauma typology, which is now going to be all military sexual trauma based. And so in that cohort, we were comparing data of what is it like when we're doing CPT as a mass model for each of these 2 cohorts, each of these 2 tracks who have very different trauma types, but are, all veterans. Do we see any differences in the gains? And we did find initially, yes, there were some gains where folks who are coming through our military sexual trauma track, they still had significant gains, but they were a little bit less consistently, right, than our combat trauma cohort. And so that was a very important sort of message that we as a program knew we needed to attend to, because we knew that, okay, CPT is really effective for a variety of trauma types. And we know that it was originally developed for folks with a sexual assault background. So what could be contributing to this gap in symptom reduction? And regardless of what it is, how do we make sure that what we're doing can be tailored so we're addressing that gap? So that is sort of the context for this slide and sort of why we're spending a considerable amount of time talking about this particular sort of additional adaptation. What we found was sort of if we spend some time attending to those factors that Jocelyn talked about in the previous slide, where we're sort of recognizing a key difference a lot of the times in between folks who are coming in from our program with MST background versus a combat trauma background, was sort of like the nature of the trauma itself and the types of difficulties that folks were experiencing beyond sort of their maladaptive cognitions. And so we found that if we added in additional skills coaching, for example, sort of what's listed on this slide here, like distress tolerance skills, emotion regulation skills, and skills really to attend to the interpersonal effectiveness of folks, we were able to sort of name the elephant in the room, which is having experienced a sexual trauma is very different from having experienced a combat trauma for folks who are civilians and folks who are veterans. And so, like, we do also provide sort of DBT based of some of these skills for both of our tracks, and we do spend like additional time and make it very specific in sort of talking with our military sexual trauma veteran cohort about sort of how this might be even more important and something that can be even more helpful due to the nature of their trauma. And we found that not only has this really helped us in bridging that symptom reduction gap, but it also resonates with our veterans. Like when we're asking them sort of what prompted them to seek out treatment, or sort of the areas, the different spheres in which they're in their lives that they're seeing the trauma impacting. A lot of it is relational. A lot of it is interpersonal. Like they're here for interpersonal issues. That's what they hope to see the most amount of change in themselves in their lives. It's such a huge motivator for them. And being able to attend to that specifically with skills coaching, we found is like welcomed and embraced and also very effective. We've also bridged that. So the second bullet point talks about MST specific staff sensitivity training. We found that it's really important for everybody on staff to be on the same page. We want to attend to two things at the same time really well. One, we don't want to vilify anyone at all. We want to make sure that we're not sort of contributing to any biases around, oh, folks who have a sexual trauma background like aren't going to sort of show as much symptom reduction for X, Y, and Z reasons. What we're trying to do is sort of frame it as trauma typology matters, and the type of tailored adaptations based on trauma typology broadly can be important in making sure we're providing truly like evidence-based, but also holistic and specific treatment. And so from the get-go, we're having these sorts of conversations with everyone on staff, clinicians and non-clinicians. And we're also like opening up these sorts of conversations, like I said, with our veterans through our like DBT or emotion and communication skills groups, and making sure that we're having these sort of transparent, direct conversations. Is there a question? Oh, you're just adding more data. Thank you. Okay. Did I miss a question about this slide? I don't.
No, there's a great question though from Krishna about what if the veteran has both combat PTSD and MST. So this is actually it's pretty common for our veterans to experience multiple traumas. When we complete the intake process and when we do the formal PTSD assessment, we collaborate with the veterans to kind of figure out which traumatic event might be the most distressing for them, and which traumatic event they'd want to focus on in treatment. So for a veteran, for example, that could be eligible for either cohort. They have combat experience and combat-related trauma. They've also experienced military sexual trauma. Really, it comes down to a discussion between the intake provider and the veteran to kind of figure out what would be most beneficial for them. What do they think would be most helpful? Sometimes in that conversation, there are experiences of combat, but the MST is really something they've either never talked about before or something that's really causing them the most distress. It could also be vice versa. So we really collaborate with the veteran to figure out which cohort they might feel more comfortable in. One of the big reasons why we have these different cohorts, which is what Miso had kind of explained, is that we find that with these cohorts, even though individuals have different experiences, it can really create this foundational cohesion and support for individuals to have some similarities. So if all these individuals have had combat experience, even if they're in different, like they're in different branches of the military or they served at different times, it still creates that foundation of cohesion, at least to start with, and that comfort. Same with the military sexual trauma cohort. Yes. Let me know if there was anything that I can clarify, though, or part of it that didn't get answered.
And yeah, and I can sort of jump in the meantime and address that question. That is such a good question. I don't know if I clarified this enough. So bottom line up front, there are sort of different studies that say different things. Sorry, I'm responding to the question of, is CPT more effective in folks with less severe PTSD? Some studies seem to suggest that that is the case. Other studies seem to suggest that that is not the case at all. They're comparable results regardless of the severity of symptoms. So I just wanted to sort of include that in terms of there are mixed results out there. In terms of what our sort of results are showing us is that we are seeing consistent gains regardless sort of like who we are accepting into the program given the exclusion criteria, right? Like after sort of attending to those specific variables, we are seeing consistent comparable results for what we do at, through our program, if that answers your question. But there are studies that say sort of both.
One other thing to note, and this is kind of an offshoot of what Vanessa had said in the chat, right? So during the intake process or during the individual sessions, there might be other traumatic experiences that an individual discloses. And so we like to be really flexible and adaptive. So if in the intake, for example, an individual discloses childhood trauma, that's something that can potentially be addressed in our program. So if they're a combat veteran that has experienced childhood trauma, we might have them in the combat cohort so that they have that foundational cohesion and comfort. But in their individual sessions, they might be discussing the childhood assault. So it's we try not to limit the different kinds of traumatic experiences that we treat here, but to just kind of keep things more simple, we tend to do 2 different cohorts. Yeah, so we wanted to just kind of take a couple minutes, see if anybody had any questions. I did notice a couple things. One of the questions is whether we're also using DBT. So one thing about DBT in particular, which is dialectical behavioral therapy, providing emotion regulation skills, distress tolerance skills, mindfulness skills, and interpersonal skills. With DBT, Because of the way individuals are trained and because of the way it's developed, it's a bit tough to say that you are doing DBT if you're not doing all of the components of DBT. So all 4 of those different components, that the providers are trained in DBT, that the providers are doing their own DBT consultation. And because we're not doing all of that, we are incorporating skills from DBT, an offshoot of DBT, that are specifically focused on the emotion regulation related techniques, the interpersonal skills related techniques, and the distress tolerance related techniques.
I have one
Can
more.
can I jump in real quickly? I just kind of want to show one more visual if you can give me the permission to kind of share my screen.
I guess I could do that.
Yeah.
One moment.
So this, I just kind of want to show people a picture of some of what Jocelyn and Miso were talking about regarding how some of these changes that we made to our programming, so the implementation of the DBT skills, both in terms of group sessions for patients and those optional consultation sessions.
You are presenter.
How those had an impact. Okay, thank you.
Mm-hmm.
Okay, can everybody see that? Yeah, okay, great. So this is what the outcome data looked like in regard to comparing MST cohorts and combat cohorts during one of the first kind of iterations of our IOP program. Okay, so both of these charts show changes in PTSD symptoms over time. The first chart there on the left is a combination of the combat and MST patients. And then that slide there on the right is the combat patients are kind of the hollow circles, and our MST patients are the darker circles. And you can see at the end there, there's a small but significant difference between the improvement in symptoms. So MST patients were not improving as much as combat patients, even though they were both demonstrating what we would call clinically significant improvements. That's when kind of Jocelyn was talking about the improvements for MST, I think, being medium to large, and the improvements for combat being large to very large. And then I can figure out how to advance this. There you go. So after we made some of these changes that Jocelyn and Miso were discussing, the differences between the 2 cohorts disappeared, such that MST cohorts were improving just as much as the combat cohorts. And so not only does this speak to the potential usefulness of maybe other similar programs incorporating some of those DBT elements, right? But it also demonstrates that those kind of distress tolerance, or we might call them emotional stabilization, interventions, can be implemented concurrently with the trauma-focused treatment, which is again really important because it goes against that model that many of us have been trained in that says, stabilization needs to happen first, right? Skills training needs to happen first before folks can do a trauma-focused treatment. And we are not finding that's the case. We're finding that it helps a lot even when they're delivered at the same time. And I can't recall whether we presented this before, but we have very, very low dropout rates to our program, right? It's over 90% of folks complete it. So with this kind of added, emotional support, folks are able to benefit from and complete a trauma-focused treatment without necessarily having kind of emotional stabilization happen first. And we're not the only kind of program to support this. I believe there's a VA program based out in Seattle that does prolonged exposure therapy as their primary kind of trauma-focused treatment, and they also provide concurrent DBT skills training as opposed to having more of that kind of stabilization phase and then a trauma-focused phase. So thanks for letting me share that. I just thought the visual might help.
Another question that was asked has to do with the family component that we have, kind of the psychoeducation that we provide. So in terms of collecting any collateral data concerning kind of the MST survivors treatment gains, we don't actually do that. The only collateral data that we collect is at the beginning when we complete the intake. To get information about from medical records and mental health records. Sometimes we might need to reach out to those providers to kind of get some clarification, but other than that, we don't do any of that collateral with loved ones.
I have one more thing I wanted to highlight. I just wanted to make sure that it wasn't missed. On one of the slides, we highlight an assessment called the PTCI. It stands for the Post-Traumatic Cognitions Index. This was something that I had not had exposure to when I was at the VA. I know in sort of traditional like trauma clinics in the VA, like assessment tools that are often used to assess for PTSD symptoms might generally be the PCL. So something that's really, I think, unique and hopeful about the PTCI is that it really does allow clinicians to zero in on the ways in which that cognitive restructuring is or is not happening during the course of treatment. So the PCL is sort of like a broader instrument that's meant to sort of figure out fluctuations and overall PTSD symptoms. So it can be really helpful, and we do administer those as well during the course of treatment. But we also intermittently are assessing for the shifts specifically in the cognitions that we're often finding, like once those change, really do predict not only changes in PTSD symptoms, but retainment in symptom reduction. So I just wanted to highlight that in terms of the PTCI as being like a very important tool that we utilize in the clinic, and that our research team have found is like sort of a great sort of flag to keep an eye on in terms of to make sure that CPT changes that you're seeing like in the room and sort of through the PCL has a really good chance of retaining even after you end treatment with your clients.
I'm happy to also kind of field the next question. There was a question about whether or not we've kind of analyzed gender differences as well as race or ethnicity differences. So we have attempted to look at that as like a control variable in basically all of the different types of analyses that we've presented. However, often in case we don't end up retaining that in our final statistical models because we haven't found anything significant. I'll add that I think one of the like weaknesses in the assessments that we do is that we have like such a like kind of one-dimensional assessment of kind of identity in terms of we ask people, you know, gender identity, race, ethnicity, and, you know, we don't necessarily kind of take into account patients' like cumulative burden of different intersecting identities that might kind of expose them to greater degrees of like trauma and stress across like the lifespan. I think sometimes using those simplistic demographic variables, it's difficult to capture that, and it's not necessarily that differences aren't there. So if that answered that question. I will also actually kind of note that although we don't see pure like kind of sex or gender-based differences, there were those differences that we discussed between combat and MST cohorts initially. And although we talked about how in the military population, there's actually much higher numbers of men who experience military sexual trauma, our MST cohorts tend to be almost exclusively female. We allow folks with any kind of gender identity to attend a cohort. We always inform patients that they could be mixed, so we don't have special kind of men's MST or women's MST cohorts. But we've continuously experienced a lot of difficulty recruiting male MST survivors. We think that a subgroup of those folks self-select into combat cohorts and end up talking about their MST and their individual trauma. But so I think there's probably a lot we don't know about some of these male MST survivors, kind of what's keeping them from engaging in treatment and how their outcomes might differ from some of the folks that actually end up getting to us for treatment. Yes, groups are can be mixed. Generally, what we try to do is ensure that when we're kind of scheduling participants for any given cohort, we try to make it so that there's not kind of one male attending by themselves. We try to work it so there's at least a couple male members if it is a mixed cohort, to kind of decrease the likelihood that a person's going to kind of be singled out. I think though, by and large, even though there's the potential for transference, as the attendee kind of mentioned in the chat, I think there's overwhelming empathy. And that goes back to kind of what some of Miso and Jocelyn spoke about in terms of folks have this shared experience. They kind of know how much it's impacted them. And although I think folks acknowledge maybe being triggered, I think they're able to work past that and support each other the vast majority of the time. But yet we also don't know how much that dynamic is keeping, again, some of the male veterans from getting to us in the first place.
Yeah, I absolutely agree. And just to kind of piggyback off of that, during our intake process, we do make it known and clear to our veterans who might be in the MST cohort that it could be mixed gender. And when we contact the veterans who are going to be in the upcoming cohort, we do let them know if it is mixed gender, just because we want to make sure that they feel comfortable and that they are making decisions that are best for them. But I have found, at least anecdotally, by and large, it's been more of a reparative experience on both sides, rather than something that's caused tension. And that's just anecdotally from my experiences. I know there might be a couple other questions, but we do have Dr. Sheila Dugan coming in next, and so I'm thinking that we transition to that presentation, and then should other questions come up, we can try to answer them at the end.
Yes, so go ahead and post your questions in the chat and we'll get to them at the end, just like Jocelyn said. Next, Dr. Sheila Dugan will be presenting on sexual trauma and pelvic health. Sheila Dugan, MD, is a professor and interim chair of the Rush departments of PMN and Rs. She sees patients with pain and functional problems related to neurological and musculoskeletal disorders. She co-directs the Rush program for abdominal and pelvic health. She chairs the Rush Women's Leadership Council, co-chairs the Racial Justice Action Committee, and serves on the ADA Committee and Diversity Leadership Committee. Sheila has published numerous scientific manuscripts, book chapters and articles, and lectures locally and nationally. Her research interests include pelvic wellness, health equity, the health benefits of physical activity, in particular in underserved populations and pain, function, and visceral fat in women at menopause. Sheila received her bachelor's degree in biology from the University of Chicago and physical therapy from Northwestern University, and her MD from the University of Illinois at Chicago. She did her internship at the University of Chicago in internal medicine and her residency at the Rehabilitation Institute of Chicago in PM&R. Prior to coming to Rush, she was on the faculty at the Harvard Medical School and worked at the Spaulding Rehabilitation Hospital. Brigham and Women's Hospital at Massachusetts General Hospital. Welcome, Dr. Duden.
Hi, thank you. And Ashton, I think you're going to put up my slides or our slide deck. So anyhow, I hope two big things you learned from today is find your local PM&R colleague to partner with. And number two, be a pelvic floor muscle advocate. Even if you're not a muscle person like I am, physical therapists, physicians, I would suggest that as you leave today, you're going to be thinking about this other set of muscles that nobody talks about. Sorry, I keep getting some message to save stuff. Here I go. Okay.
So sorry, it's making me go.
No worries. Let me post the chat here. That's you doing all that. Okay. It's always funny when someone else is running the slides and you're trying to change what's shown there when actually it's Ashton's work. So welcome everybody. At every VA hospital, you're going to find physical medicine or rehabilitation physicians. Historically, that would be related to veterans that have had neurological injuries like brain injuries or spinal cord injuries or amputations. But in my era and moving forward, I hope you'll be finding more physicians of physical medicine or rehab that really want to work with you on the pelvic floor and just general functional outcomes of trauma, in particular military sexual trauma. And I have had the incredible great fortune of working with these fabulous behavioral health folks here at Rush. We are very biomechanically trained, and many times within the course of a physical therapy treatment, people will disclose what's happening to them. And many times the therapist is sort of left with information and not knowing what to do about it. So we really partner well at the institution across the street, which is the Rush University Medical Center. But I had the joy of working with the Road Home program now for probably 5 years. I'd like us all to understand the link between trauma and things like pain, local pain, even referred pain, as well as urinary, gastrointestinal, colorectal, gynecological, and sexual dysfunctions in veterans that have had military sexual trauma. Talk about some clinical reasoning that we use as we are thinking through patients' complaints. And as we do our clinical reasonings, we're big educators, just like you all are educators about how people should be noticing how they're feeling about things and how those feelings are expressed in their body. We do a lot of education using information as much as a veteran can tolerate regarding muscle, where things begin, where they end, what job they do, which starts to really give the veteran a little aha moment of, I knew that my belly pain came after my sexual trauma, but every time I saw a physician, they either muted what I was asking or they did a test and said there's nothing wrong. So clinical reasoning helps the provider as well as the client or the patient. And then how do these pain generators start to change what you can do or can't do grossly from exercise or walking or sleeping, and then specifically for relaxing your sphincters to have a bowel movement or to empty your bladder completely, or to have your muscles become aroused when you are sexually aroused and lubricate and cause orgasm and all the other things that change after a military sexual trauma. And we'll talk a bit about dialoguing about the pelvic floor. Even though you're all going to become pelvic floor advocates and zealots, you're not going to be the one necessarily getting into the specific treatment of the pelvic floor, but just being thoughtful about the anatomy, the physiology will make you somebody who can have a moment of, I wonder if your symptoms are related to your pelvic muscles, and I can work with someone in our community that can help us with that. Also to maybe give the client some idea about what the examination can include if acceptable and tolerable. And then how do we think about treatment? And that's really mostly done by pelvic floor physical therapy. Over the last year, I would say, I'm hearing more from our cohort veterans that they have a physical therapist who does pelvic floor at their VA. There's one in Manhattan, there's one of the California VAs. At Jesse Brown here in Chicago, we have a pelvic floor physical therapist. So what does a pelvic floor therapist do? How do we find them conveniently located? Many times they locate nearby to the VA hospitals, because if you don't have a pelvic therapist, then you may have to recommend somebody outside of the program. Okay, next slide, thanks. So what's the what, the where, and the how of the pelvic floor. So, what are these muscles? Where are they located, and how do they function? So they're all located within the confines of, if you were sitting now and you put your hands on your hips, those are your iliac crests, and inferiorly and towards the midline is where the pelvic floor muscles do their work. They support our organs against gravity. They have specialized openings you can kind of see in the picture. The picture makes it look like that space is wide open. That's the anal canal, but in fact, there's specialized sphincters that control the passage of stool, and likewise in the urethra that control the passage of urine. There's a sexual function to the pelvic floor in terms of orgasm and blood flow as there is arousal, and then stability for the pelvic bones and the spine. So many of our veterans not only have pain or difficulty eliminating, they also have associated belly or back pain because these muscles don't live, in isolation. They're connected to the abdominal wall, the back muscles, and the leg muscles. Next slide, please. And I should say, as you see that one reference, 1942, this is not new. We've had these muscles as the human has gone into an upright position. You need muscles to control the output. It's pretty profound, the lack of knowledge about these muscles, which is partly sociological, as though it's not okay for healthcare providers to ask questions about urinating, defecating, sexual function. But it does become something that has been muted, and even in medical or nursing or physical therapy or occupational therapy education, there's not a whole lot historically that's been taught. And it's really, I would say, over the last decade that there's expectations for teaching and for capability, which was set back pretty significantly by Dr. Nasser, who was a sexual predator, who was in the sports medicine world, to the point where Michigan State ended up with large lawsuits that has impacted other universities about teaching pelvic floor. And again, this idea that what we're doing is inappropriate. It's inappropriate if we're doing it without the consent of our patient or our clients, without informing them about the opportunity for understanding what's happening with their muscles. And again, I always tell clients, this is not cancer. In cancer care, we sometimes have to do things that are very invasive, medicines that have horrible side effects. In the setting of musculoskeletal care, we're offering up the clinical reasoning as much as people can kind of be there and want to talk about and understand it, the chance for an examination, and then the chance for some treatment. And within the treatment realm, you can choose what you're comfortable with. So just because we examine the pelvic floor as one of the things we do, if a client doesn't want that to happen, that's absolutely fine. And we can talk about his or her symptoms of the abdomen, defecation, urination, sexual function, and make lots of recommendations by simply examining the muscles that attach externally. So I don't want you to think there's also a one size fits all. It's really welcoming people into the space to understand the mind-body connection of MST. So really, many providers have no knowledge of pelvic floor musculature function and dysfunction, even if you have local organ expertise. So gastroenterologists or colorectal surgeons or gynecologists or urologists don't necessarily study the muscle, what happens with scar, what happens with the inability to relax. And so they oftentimes rely on traditional diagnoses like, well, I'm going to get an ultrasound. You have pain in your left lower quadrant. Oh, the ultrasound was normal. So therefore you have no pain? Therefore, we need to keep figuring out what's wrong. And so many times there's not a framework to consider muscles, nerves, joints. You can't see a tight muscle on an image. So if you did an ultrasound or you did an MRI, you're not going to see the muscle. You need to listen and, if able, examine the patient to understand what's going on. And these also cause problems for, as I said, GI, GU, urological, colorectal, and all the other symptoms that bring you into the realm of these other physicians who are sort of thought to be the yes or no decision makers. And yes, we had heard earlier with MST, but across all of care, female referrals are much greater than male referrals for pelvic floor assessment and care, as though, oh, men don't have pelvic floor muscles? Well, sure they do. It's interesting to the point of where the American Physical Therapy Association, women that, mostly women, there are some male providers that get expert training and take tests. They're called women's health physical therapists. And this is because the origin of caring for the pelvic floor really was sort of carrying and delivering a baby. So it was a lot of women that were showing up with pelvic floor issues that really weren't being well managed. And PT said, we can help with this area. So we need to change our language even around women's health PTs take care of pelvic floors. Pelvic floor physical therapists take care of pelvic floors. Next slide, please. So how do you develop a template of how and when to refer a client for some pelvic floor providers? At Rush, it's easy. When folks come for the Road Home program, the nurses and the intake folks talk about the pelvic health treatment that we have available and whether people want to opt in or not. They want to tell the client, what does the assessment look like? And then you want to figure out in your community, who could you partner with to provide evaluation and treatment, since you don't have this team where all of you are. So definitely a pelvic floor provider, and I use that term broadly here. Not every physical medicine or rehab physician is interested in or trained in pelvic floor. That's an area of my great interest, and I work with a cohort of people locally and across the country, but they're not as easy to find from a physician perspective as it would be to find a physical medicine or rehab doc that takes care of back pain. Pelvic floor physical therapists really do have a larger network, and they are very linked into other providers in their community. So let's say in your community, you find a pelvic floor physical therapist. I will say it now and remind you later that the American Physical Therapy Association, the APTA, on their website can lead you to a pelvic therapist, but you have to search for a women's health physical therapist. So again, kind of crazy. It goes back to the, sort of the history that this is somehow offered to women more than men, which is not appropriate. And those physical therapists in your community might be able to then link you to a physician who they've had good success with. Sometimes it's a pain physician who's able to do some local blocks or other medication management that the physical therapist needs to do her work. And then how can you prepare the patient? You can differentiate that when you see a physical therapist, they're going to examine you, they're going to talk to you, they're going to examine your muscles. And then if they are concerned that the muscles of the pelvic floor are involved, they might also include a pelvic or a rectal exam, which is not like the pelvic exam you might be getting from your gynecologist, or if you're an older male, it's not like the rectal exam you're getting for your prostate. It's actually an examination that includes muscles. This would be described, we would show images or a model, and we would offer this. You could have someone with you if you wanted to have somebody with you. If the exam starts, we can always change our mind and change our path. So it's one of these kind of opt-in if it feels like the right thing, if it makes sense to you, and you feel like you're being well educated. And I sometimes use the analogy that I'm the container doctor and I work with all these organ doctors. And the organ doctors just sort of don't think about the container as a pain or a functional problem generator, which is exactly what a rehab doctor thinks about, is your overall function. How do we meet you where you're at? And what are your goals? And how can I help you get there? Okay, next slide. I assume we're taking questions at the end, but keep some questions in mind. I put this slide in specifically to remind you and me to think about males with pelvic pain, because chronic pelvic pain, there's lots of literature, mostly coming out of the female literature of urogynecology and gynecology. Men have pelvic floor muscles. Men have pain. Men get labeled with diagnoses that do not describe what's going on, and then they're given tests that are supposed to be either positive or negative, and then they're pushed away if they're negative to say, I don't know what's wrong with you. Or there's some lab work we're going to do. So if you have white blood cells, we're going to somehow call it an itis, an infection. Men get, I would say on average, 5 rounds of antibiotics before they may luckily find their way to me or a urologist who thinks about muscles or a physical therapist. And usually it's your prostate, period, as though in the male pelvis, there is one organ that urologists think about, which enlarges when you're older. Now, when you're 30 and you are revealing that you had a sexual trauma, to sort of try to put the onus on the prostate to be yes or no the pain generator, which of course, if you're 30, the tests come back normal. So the etiology, they will say, may be related to a psychological stress or dysfunction, but then they want to always tie it back to something that you can test in the medical center. So patients oftentimes need to keep advocating for themselves. And one of the things that we had more time to do when we have our longer 3-week IOP was to actually do some role playing to say to go home to your physician, okay, I met this physician who told me that these are the muscles that are having problems and this is why I'm having trouble with dysfunction, and I need to be referred to somebody who can help me, which is a pelvic floor physical therapist. And so they've had this experience of being sort of blown off or treated as though, oh, here comes Mr. So-and-so again. I don't know why he's in the office. And if they can't find the source, to sort of, again, say there's nothing wrong, rather than thinking, is there a particular tissue issue? And we could sort of just, start to frame up what's wrong and what to do to take care of it and change the position of the patient in terms of their pain or their functional problems. Okay, next slide, please. So when you're talking about the pelvic floor, again, many times it's a new area, and in particular with our MST cohort, there's a lot of sensitivity. We already mentioned that everybody has to have the same level of sensitivity. Listening to a patient list their symptoms, the nature and the onset is very helpful to me start thinking about the clinical reasoning and what's going on. So it's really important to hear it come from the person themselves. You can use things like pain scales and visual analog scales to sort of help you decide whether your interventions are helping. So if you have a pain scale, when you meet the client and then you have an intervention, it's nice to know that the pain is heading in the right direction, as an example. It's nice to know what things make the pain go higher when you're starting to think about what tissue is if it hurts to sit for a long time, what particular tissue is under stress, let's say, in that sitting. There's other larger things, scales like the International Pelvic Pain Society scale, which is very comprehensive, which again can help us if we start thinking about maybe some research on what we're doing and how it's helping large groups of people. Having somebody point to the location of the pain, it's really important. If somebody sort of points to their entire abdomen as hurting, rather than it hurts right here, it starts to help me realize more about, is it a local muscular phenomenon, or is it more of a centrally maintained pain where there's a large referral throughout the entire abdominal area, for example. Talking about what helps things get better and what makes them worse is extremely helpful in terms of, again, thinking about locations of muscles, functions of muscles, which nerve is in the area, how do you relieve something by changing positions. Talking about sexual history, abuse history, and other trauma history has been something that I have, been able to evolve as a non-behavioral health provider through the help of my colleagues. I'm looking directly at Vanessa in particular. Dr. Tyrone has been very helpful for me for things like saying, the medical literature shows that sexual trauma is associated with pain and dysfunctions. Has anybody ever put something in your vagina or your rectum against your permission? So I'm norming why I'm asking the question, and then I'm asking a very direct question, and I'm not sort of couching it in something I'm not comfortable with. I would say when I was a young rehab provider, I would say something like this. Okay, now I'm really uncomfortable asking you. Can I ask you one more thing? And if you don't want to tell me, that's okay, but have you ever been raped? Okay, I've already said that this is abnormal for me to ask you. I'm not comfortable asking you. And what does rape mean? So for me in my area, and again, keeping it real and keeping it clinical, I want to figure out what's going on with your muscles. And I want to know if anybody's ever put something in these openings without your permission, because I know that the literature would say if that's happened to you, you're going to have trouble with pain, possibly urinating, possibly defecating, possibly with your sexual function. So now I'm offering this as a moment to share information together, to say you're not the only person, and to also let them say that they do or do not want to disclose in this moment, but to plant that seed. So for me, it's a much more positive interaction. I feel better, which shows on my face. I'm sure that hopefully the client feels welcomed into that space. And I would say that our physical therapists are finding out people do disclose to physical therapists. They come in for back pain, and they're talking about things. So as a physical provider, we need to have the skill set, and I'll talk in a minute about a trauma-sensitive approach that we use at Rush, where we taught providers, which really was good for outcomes for us and hopefully for our clients as well. Other things that might clue you into sort of ongoing problems with defecating, urinating, sexual function is how do the organ systems themselves then feed into these over-messaged muscles? So during your menses, as an example, when your uterus fills with blood, it's not very happy, it's a noxious input, and then that organ, the uterus, tells the muscles to tighten up. So for that last 5 days or so, and as you start to menstruate, your muscles are tight and then they start to loosen up. So how does the organ system then feed into this? And I really learned pretty quickly that besides the MST experiences, veterans go overseas, they eat food that they're not used to, they defecate in public places, or they hold on to their urine or their stool for hours. And so all these things only sort of serve to increase their problems. And many of the combat veterans that IOP veterans that I see have lots of pelvic floor urinary defecatory problems. So anyhow, there's this sort of feedback loop that just makes things keep getting worse and worse. More providers get into the mix. If you're lucky and you advocate for yourself in the system, and these providers do tests that don't help with distinguishing the cause, and in fact are very invasive and very uncomfortable. So a colonoscopy comes back normal, but now the patient feels worse because we've just put air and a big tube into their system that's already too tight and already they're bloated or et cetera. So also, you know, how do we think of intimacy again as a role, a functional role that we all have in our lives that we can participate in? And even things like, for me, using the analogy that when I put somebody back to, I'm a sports medicine doc, when I put them back into their sports, I don't put them into a game and, you know, 9 innings of a softball game where they're playing shortstop. I might have them throw the ball off the wall or play catch, right? So how do you think about your own system and figuring out for yourself what works before you bring a partner into the mix? So there's all sorts of really helpful ways to give control back to the client or the patient. Next slide. I'll go talking on and on, so you guys make sure I'm watching the clock too. This is my area of passion. It's just underrepresented and undertreated. So this is a picture from a book or a mini monograph that was used to teach, you know, physicians. Here's a disrobed patient. She is looking uncomfortable. The practitioner is not looking at her. I mean, I've heard horror stories of not just one practitioner, but multiple practitioners in a room in a way that's completely unacceptable and not how we think about this. Before I even get to the physical exam, I'm going to be explaining to a dressed person what I want to consider, how I might, you know, palpate muscles. So I'm going to use a model, if that's okay. Again, asking somebody, will a model cause you to be uncomfortable or trigger, or is that okay with you? Great, okay. And then using the model to show the muscle, where does the muscle begin? Where does it end? What's its function? How might I insert my finger? Not to do a general gynecological exam, which is with an uncomfortable speculum, which takes, you know, tissue from your cervix. If it's a pap smear, it's a digit. It can be removed immediately if you're not comfortable. So we're going to get consent, but also know that we can stop this in any way. We can change the position you're in if that's making you more or less uncomfortable. In a different scenario, we see women that have trouble going for their gynae exam and they come to physical therapy and they sort of get to know the speculum. They see it as not this cold thing that's brought out of, you know, out of a cupboard somewhere. I mean, so sometimes there's not only the MST, but there's other negative experiences with healthcare providers causing, you know, PTSD from a physical exam perspective. So getting consent, you can have someone in the room with you if you would like, of course. Letting them know that the abdominal pelvic exam could be provocative, asking, has this been the case before? What can I do to make this more uncomfortable? Acknowledging that flashbacks can occur and to let me know, and we can take a breath or we can change the procedure altogether. Consider positioning so I can see his or her face while I'm doing the examination, and actually empowering the patient to decide on, is it going to be a hand up? Is it going to be, can you stop? Whatever plan is to change the direction as needed. Next slide, please. So we then switch to a gown, if that's okay, because it's really helpful to me to get some knowledge around, you know, generally speaking, how is the patient altering the way they stand, the way they sit, the way they move, and watching their face? Do they have normal motion of their low back? Do they have lower extremities that move well at the hip and the knee? Do the muscles look the same? Is there any side where there is wasting away of one side, which then makes me want to include some type of neurological impact, not just a myofascial or muscle impact? There's really commonly muscle pain in the glutes, the piriformis, which is just deep to the glute, and then just deep to the piriformis lives the pelvic floor, yet we teach providers about the first two layers and we completely pretend like the third layer doesn't exist. Anyhow, there's also muscles on the inside of the leg called your adductors that might be very tight in regards to especially trauma and the way that you are sort of protecting yourself. And then there's a big muscle that comes from your back called the psoas muscle, and it attaches to the iliacus muscle, and the two of them lift your leg up. So every time you step forward, you use your iliopsoas. Every time you step up on stairs, every time you stand on one foot to try to put your leg in the other pant leg, you use your iliopsoas. So you've already heard from the person what things are in trouble, what's not working so well. And then there's all these layers of abdominal muscles that get completely missed when you think about how we diagnose GI problems. And these muscles, just like your trap muscle or your glutes, they can get trigger points. So there's all kinds of ways to examine the abdominal wall. And then a lot of clients have had surgeries or trauma, so scar tissue from surgery can impair the ability of the abdominal wall to expand and contract. It's really fantastic to be part of a group where clients are learning yoga and yoga breathing and things like the astronaut position for mindfulness meditation, which means you lay on the ground with your legs bent and your feet up in a chair, which completely puts your psoas muscle in a relaxed position. So throw a little heating pad over your abdominal wall and your psoas while you're doing your mindfulness meditation. And that's like a 3 for 4 or 5, a 6 for 1 in terms of what kind of benefits it can help our clients with. Next slide, please. The physical examination of the pelvis itself. Again, there's maybe some scary pictures to people on the right there. This is not a slide I would use with my clients. This is to teach you about what I'm thinking about when I examine a patient. So if I think someone has carpal tunnel, I know that the median nerve supplies just these 3 fingers. I know that the muscles of the median nerve includes this thumb muscle. I'm going to resist the thumb motion. I'm going to look at that muscle to see if it looks wasted away. I'm going to palpate to say, do these fingers feel number than these fingers? This is the same thing I need to do in the pelvis. What sort of scar is there from the trauma itself and or labor delivery, or let's say prostate surgery in a male? Is there any prolapse, which is when the tissue weakens and the organs start to protrude out, which puts its own amount of stress on the pelvic floor, regardless of trauma, no trauma? What's the neurological function? If I lightly stroke, does it seem the same on each side? You can use a Q-tip to see if there's actually the feeling of pain instead of just a light stroke. And then what about strength? With my finger in the vagina, can the patient squeeze and let go? These are just simple, straightforward things we do in any part of the body when we're trying to figure out, is there a nerve impairment? Is there a muscle impairment? And just even some reflexes. If you lightly stroke on the inside of the thigh, you should see the sphincter of the rectum tighten up. So these are all things we do to look at the health, the current status of the neurological function of the pelvic floor, because unfortunately, trauma can cause a change in neurological function. Next slide, please. So again, if I'm going to do a physical exam of the vaginal muscles or the rectal muscles, I want to be able to see the patient's face, and I want to be able to think about, where does the pelvic floor muscle begin and where does it end? So for instance, the pubic bone, which is that very tender bone, kind of right under where you zip up your blue jeans, and your sacrum, which is the triangular bone at the base of your low back. Those are the 2 anchor points, and the muscles sling from front to back, and they have a right and a left sided. And as I'm palpating, depending on the patient's sense of, would you like me to tell you what I'm doing versus are you better just relaxing and in your own head and taking some deep breaths? But I will be palpating to see if there's a difference on the right versus the left side. We sometimes educate with a clock face analogy. So if somebody is in, let's see, the position of stirrups, I don't use stirrups. I find them to be, I don't know what, horrible personally, but their knees are bent up. If you look at the perineum or the pelvic area, the pubic bone would be like 12 o'clock, the sacrum would be 6 o'clock, and we use a clock face analogy to talk about 3 o'clock is on the left side, 3, 4, 5, 6, and then 7, 8, 9 would be up on the opposite side, so that we can start to associate, yeah, that's the pain I feel when I'm being sexually active, or that's the pain I feel when I'm trying to relax to pee. And you can, just like you might say in someone's neck, is this the pain you feel after you've been on your computer for 6 hours? It's the same kind of concept. And again, if there's problems with posterior pain, coccydynia, which is a painful tailbone, troubles relaxing to defecate. I may also do the same kind of digital examination around the rectal sphincter and muscles to see if I can corroborate pain and dysfunction and then make a path forward for treatment. Okay, next slide, please. As I mentioned a few slides ago, trauma-sensitive care is critical and not necessarily part of your usual medical education, quite honestly, and physical therapy education. And it integrates this idea that we're all compassionate medical care providers, but we don't really know necessarily psychological best practices with trauma survivors. And again, must be applied consistently across the whole Road Home program, and in particular, educating us up. One of my other faculty members is a traumatic brain injury expert, and he also comes over and does assessments for TBI and needs to be knowledgeable about trauma-sensitive care. Short-term goal is to reduce new trauma or trauma exacerbation at the visit. And as I mentioned before, we hear stories all the time of medical care providers inducing additional trauma. And the long-term goal is to help the patient have a safe and pleasurable sexual experience, as this idea that being insensitive and not sort of framing this up as, you know, this is your long-term goal and we're going to get you there, just like we do with an athlete. We're going to get you back into the sport that brings you into my door that you cannot participate in, so that people know that there's nothing that's permanently wrong because their muscles are too tight. We expect that this could happen. These are the outcomes we see, but there's not necessarily a permanent path to you'll never have pleasurable sex, you'll never be able to, you know, bear a child if that's what you decide you'd like to do. Okay, next slide, please. So, you know, we agree that the Rush pelvic health providers were compassionate and we're trying to be responsive to patients, that standard physical therapy could trigger these symptoms because of these invasive techniques, and that they frequently spend more time with patients, allowing greater communication. So the opportunity was they're hearing about these traumas, and the limits were that we really weren't trained, even though we cared about it. We didn't have the sort of training and the realization that we could be triggering as much as we were helping. Next slide, please. So we did an intervention that was both for the clients and for the physical therapist, which again, I think interventions that are multi-targeted are always really excellent. For the physical therapy, interventions on the right was techniques to reduce pelvic floor hypertonicity. So just like you might do a progressive relaxation with your neck muscles, you could do similar things within the context of your physical therapy appointment to help a client tolerate or experience what was happening. Yeah, how to assess for a sexual abuse history, how to reinforce use of assertive communication for our clients, how to reinforce use of anxiety reduction at the moment, you know, in the moment of the exam or the treatment, and then providing positive messages about sexuality, which I already mentioned. And at the same time, the patients in the study were learning about psychoeducation, the kind of mind-body connection, how to do relaxation skills during treatment and outside of, how to communicate assertively and know that it was going to be well responded to, not like other providers that might sort of say, you know, be quiet for a minute while I finish my exam. Those sort of things that we hear all the time. What about pain management, and how do you ask about, you know, this treatment's uncomfortable, can you help me with other ways to manage my pain? Which oftentimes then the physical therapist would come back to me to say, what else could we do topically or orally to help with pain? Challenging sexual myths, again, this sort of idea of there's one way to do things, or that you're always going to have trouble with sex, etc. And then, you know, how to sexually communicate. So as you're learning things about your body, how do you bring others in your lives, in your intimate life in, and they could help learn and understand. So we called it the RESPECT Study, Restoring Emotional, Sexual, and Physical Empowerment through CBT and Trauma-Sensitive Care, a Chronic Pelvic Pain Intervention. And let me tell you, we need as many chronic pain pelvic interventions as we can get, because chronic pelvic pain is really a problem, and it's with our MST folks as well as others. In fact, there might be somebody on this call right now. Oftentimes when I speak, someone comes up afterwards about themselves, their sister, their girlfriend, you know, whomever. So it's common, and it's not talked about, and it's missed. And this is very helpful. So 7 sessions cognitive behavioral intervention began before the initiation of physical therapy, so that both we were ready and the clients were ready, and it came together. Next slide, please. So if you have the chance to cross-reference each other, it's very helpful. The other piece I wanted to bring up is that it's not a uni-system problem. if you have a problem with one of your openings, you have colon cancer, and now we've done a surgery to your rectum, guess what? Your urination and your sexual function will change. It's kind of like if you, I don't know, if you had a problem with your upper trap muscle where it attaches behind your ear and was causing headaches, it's also going to pull on the muscles that go down to your shoulder. And so if you show up with a shoulder problem, I'm not going to image your shoulder. I'm going to be listening to the connectivity of this muscular system. So if you have a problem with sexual assault, no matter where, how, the entire sling of muscles from that pubic bone to that sacrum are at risk of having too much tension. So we know that as providers, and I am the one in our pelvic health clinic on the Rumsey, Rush University Medical Center side of the house saying, send me all of your people with problems defecating, urinating, lubricating, because they're all going to be related. We also took a look at veterans who experienced MST. They were in our cohorts, and they had a prior childhood sexual assault, and they demonstrated worse PTSD symptoms. There were 174 veterans who were seen for pelvic exams through this mechanism where, again, they're offered to talk to me and then offered while they're in with me to have an exam, and I can make some recommendations for physical therapy. About half of them had a history of at least one childhood sexual assault, and most, about 45%, most had either 4 or 3 systems involved, and those systems included urinary, defecatory, sexual, and let's just say pain in general, so pain. So about half had all 4 complaints in all 4 areas, and another third had 3 systems involved. Interestingly, the history of childhood sexual assault was not found to be statistically associated with the difference in the number of involved systems, and we had postulated that those with sexual assault in childhood would likely have more systems involved. We didn't see that difference, but I can just say that 45 plus 35 means, 80% of people in the cohort had, more than 2 systems involved. So again, the idea that you see a urologist or you've gone to the gastroenterologist and they've cleared you from the, why you're having your symptoms just doesn't make sense. You need to have an integrated approach to the pelvic floor in regards to pain and function. And this is a poster that we're putting forth in an upcoming meeting and hope to get a manuscript out there as well. Okay, next slide. Okay, so again, what are some of the patient empowerment tools that you can, along with the recommendations to see a pelvic therapist, you can also give your clients acknowledge as a chance of triggering the PTSD, and consider the likelihood of avoidance, not only in that one moment when you make the recommendation, but the literature that says that folks that have had sexual trauma don't go for child care visits when they're pregnant, and all sorts of other things. There's association with childhood sexual trauma and having diabetes or metabolic syndrome later, obesity. There's all kinds of ways that this is going to show up in people's medical health. And you at that moment can remind folks, this may seem like it's a small step. If you're ready, it's a really powerful step. They need to advocate on their own behalf. I mean, no one sits around that I know of talking about their painful vaginas. I mean, that I've been around, and I sit with my friends and talk about a lot of stuff, and I'm a provider. It's just not necessarily the social norm, and once you teach people and they do get other people in their lives, they might say, oh my gosh, I talked to my sister and you won't believe it, but this has happened to her and she's also having trouble. And even providers are going to lack the knowledge, and they might make their provider uncomfortable. So we actually give people like a sheet of paper with here's the data that says if you've had sexual trauma, you're likely to have multi-system involvement, and here's some information about getting this evaluated and treated, because you might be the only one in the room, I tell my veterans, who knows about these muscles, and you're gonna have to go home and advocate for yourself. And you might make other people uncomfortable, but again, the reasoning, what we're doing is just very similar to what doctors do in all kinds of areas. They just are not knowledgeable. And when you call back after your test is normal, the way the system works is your test is normal, see you later, rather than that test was normal, who else can we bring onto the team that can really solve the problem and work together with us? Okay, next slide. Okay, I have a few references, but there's a huge literature. This is not anything new. there's a disorder called vulvodynia, where the vulvar area is the non-hairy opening of the vagina, which includes the labia majora and labia minora. And in 1887, someone talked about vulvodynia. Yet, again, people don't talk about this from the perspective of, how do you think about an area of the body that's having abnormal sensations? What are the other ways that nerves work, oddly or in a way that's exuberant? They sort of say, oh, it's in the vaginal area. We're not going to talk about it. We're not going to think about it. So this stuff is part of our anatomy. It's a part of our life's functions. The pelvic floor physical therapy experts that are available through the American Physical Therapy Association website. Again, it's the Women's Health PT Locator. And I think nowadays you could literally Google pelvic floor physical therapy in your community, and you would get a large response. Some of my male clients have to go home. I tell them you have to call and figure out, do they take care of men and women? The way pelvic floor physical therapy is taught, you start with sort of the female anatomy and the common things like labor and delivery, gynecological surgeries, and then you layer on the male anatomy, you layer on gastrointestinal problems, you layer on post-cancer patients, be it colorectal, gynecological. So a new provider may not be the person that you need, nor will she have the kind of skill set that you need. So there's a bit of homework that needs to be done as well. Before I retire, it was my goal that every VA has a veteran physical therapist who knows the pelvic floor, and male, female, knows MST well, and that we can have that provider really handy and available to help. But in the meantime, my national colleagues, there's many that treat and are near the VA systems, and they understand that that's a source for pelvic floor issues for certain. I think that's my last slide, right, Ashton? Okay. So I haven't been watching the chat, so let me go over there and take a look and start looking at some questions. International Pelvic Pain Scale. Go ahead.
Oh, sorry. I was just going to say that Ashton and I have been compiling a list. So if you miss any, we got you.
Okay, great. Okay. So anyhow, the International Pelvic Pain Scale is, as I believe it's available, publicly available. There are some scales that you have to, pay for or ask permission for. So I think you could just Google that, and maybe I see Vanessa has her head down. Maybe Vanessa could pull it up for us. Let's see. Is there a chart or resource that lists common medical issues associated with sexual assault? My first response is there are so many, it might be hard to list them all. And I'm wondering if there is anybody that's done a sort of general overview of this sort of medical, again, there's metabolic issues related to sexual assault in the long run. There's momentary, there's acute issues related to sexual assault medically in terms of trauma, laceration, etc., infection, STD testing, and then there's these sort of subacute and then chronic issues related to sexual assault. Oh, thanks. There's the International Pelvic Pain Scale.
Literally just Googled it. Super easy and free.
Great. Questions? Love to know if Dr. Dugan has a specific self-report measure that she recommends to assess pain. A lot of the, so the International Pelvic Pain Scale is really long and kind of a commitment. The visual analog scale is one that we sometimes use in studies. It's not very satisfying. The numeric rating is another thing that people can self-assess. And there are separate, like we've tried to put together, there are separate scales, sort of urological scales that include pain, or the gastrointestinal folks might have scales about pain or constipation. So it kind of depends on what you're interested in, but I think monitoring a number is one way that we can say 0 is no pain and 10 is the kind of pain that you need to go to the emergency room for. These numbers, a 10 is specific to me, because if I've had pelvic pain for 10 years, then to have to go to the emergency room, isn't going to happen because I've been through the ups and downs. Whereas somebody who's new to pelvic pain may be showing up in the emergency room thinking that it's a 10/10 for them. So again, that numbering system is at least kind of specific to an individual.
I was going to say as well, like there are probably differences in the detail, like Dr. Dugan might need to assess as a medical provider versus like what we might need to assess in order to at least like educate the patient or like give them referral resources. So when we speak with potential IOP patients and we're doing our intake interviews, we ask them like pretty simple questions like, do you have any pelvic pain? And so a pelvic pain would be any pain that you experience in the area between like your belly button and the bottom of your underwear, basically. And then kind of as a follow-up, we can ask questions like, the reason, we also usually give like a introduction, just like Dr. Dugan talked about, right? The reason I'm going to ask these questions is because we know that a lot of veterans have, pelvic health concerns or pelvic pain. We can also ask questions like, do you have trouble doing things like kind of peeing, pooping, or have like pain or discomfort with sexual activity? And so as the mental health care provider, those questions often like are enough to kind of give us something to go on to know which patients might need to see a Dr. Dugan or like a pelvic floor physical therapist.
Yeah, and I see this thing, is there a chart or a resource that lists common medical issues associated with sexual assault? I don't know that I've seen that. It doesn't mean it's not out there. And if it's not out there, then maybe we could help with creating it. There are studies that say if a woman comes into a gynecological office for pain with intimacy, she's more likely to have troubles with defecating and urinating if she was sexually assaulted. So those are things that we feed back to the gynecologist's office who is treating her for her presentation of pain with intimacy to say, are you asking questions about, urinating and defecating because they're likely to be impacted? Well, first of all, are you asking questions about, has anybody ever put anything in your vagina or your rectum without your permission? And then associating that with the likelihood that you're at higher risk of not only, vaginal issues, but urinary and defecatory issues as well.
It can also show up with like other types of activity, like Dr. Dugan, feel free to add, but like some folks with pelvic pain have difficulty sitting for long periods of time, like at a work desk. So it doesn't, the pain doesn't necessarily show up kind of like just with sexual activity. It could be kind of more of these like everyday sorts of tasks or positions.
Absolutely. And most of our veterans are sent to kind of an orthopedic model if they have back pain or pain sitting or pain in their hips. And if the orthopedic model doesn't, again, just include this layer of muscle, I mean, honestly, these muscles exist, they're just not taught. So you now know about these muscles. So it may be that little aha moment. You've already been for care. It hasn't gotten better because perhaps the differential diagnosis was too short and this needs to be included. And so helping people, one of the things I do a lot is to help people understand, what I think it is and what I think it's not. So going through carefully, I know you had an MRI and there's a degenerated disc at L4-5. You're 50 years old, so more than half the population has a degenerated disc. I see no other signs or symptoms of nerve involvement from that disc. So let's just take that off our list. So many times by eliminating these other worries people get, oh my gosh, did you see my MRI of my disc? That there's another piece of, okay, you did your homework, you've seen the right person, it's not what's causing your problem. So that feels better than somebody sort of blowing you off without explaining, what it was about that image or that test result that does or doesn't relate to, how you're kind of coming in the door with the complaints that you have. And again, these veterans fall off of Humvees, they crouch. I mean, they have all kinds of other reasons to have, chronic musculoskeletal problems that are then further exacerbating or, the basis for their additional problems after their MST. Well,
Also, to kind of tie some of this a little bit back to the work folks might be doing in CPT, oftentimes folks can have kind maladaptive cognitions about sex or about pain that have kind of impacted how they've dealt with this over the years, right? So it's not uncommon for folks to have beliefs like it's normal for sex to be painful for a woman, or sex is something I'm obligated to provide my partner. Sex only counts if it involves a penis penetrating a vagina. And so some of these beliefs, if they're held really rigidly by the patient, can contribute to them like kind of ignoring the pain. And so again, like part of our role, and this can even be done in the like intimacy section of cognitive processing therapy, can be to educate patients to help them work on some of these beliefs. And that can kind of open the door and create more willingness to actually like seek care or to be assertive with partners to resolve some of these issues.
And there's just another reminder of how incredible it is to work as a group together to be able to, you know, not only make better diagnoses, but then to reinforce, you know, how assessment and treatment can be helpful. So I do encourage everybody, thanks for your attention. I wish I could see you all. I'm a people person. I'd be walking around the room and making eye contact. So I hope that you've learned a lot today. And if I can be of any further help, or if you want to reach out to your local pelvic floor physical therapist, she or he, mostly she, will be extremely helpful to you in kind of, you know, finding a path for your clients and your patients. So good luck.
We do have another question, Dr. Dugan. It says, given the avoidant nature of survivors of sexual assault, I wonder how many people delay medical exams.
All the time. And I think, again, you know, welcoming people to telling their story and giving them some, you know, grounding about why they might be having symptoms and what tissue might be the source of the symptoms, and the ability to have an assessment if they're ready for it. And sometimes they're not, and it's not the first visit that I even do the physical exam. So yeah, so I think it's a real problem, but not one that can't be addressed with patience and understanding.
We
All right, so
also
while we're
do
doing,
have pretty good like uptake exams within our program. So I think it's around like 70% of veterans actually volunteer to have a visit with Dr. Dugan. And they're given the option, like Dr. Dugan said, to either kind of just do an interview and learn more about things, or to receive a physical exam, which could include some invasive components or not, if they don't prefer that. And so like the vast majority of that 70% who meet Dr. Dugan also do complete a full kind of internal pelvic exam. And so I think that also suggests that if we can provide folks with like the appropriate psychological support while they're engaging in this type of medical care, that it like can be really well tolerated.
all right, so while we're doing the wrap up, I did post a link shortly, and I am receiving some feedback saying that you need an employee ID. Give me one moment. I'm going to be working with our IT tech to see about that. But I do want to thank everybody for attending our training. For those who have registered for CEUs, please fill out what was posted in the chat. If it doesn't work, we are going to be sending this out via email. Again, this is only for those who have registered via the Eventbrite for the CEUs. The survey is going to be active for 10 days. So again, if we can't get this fixed, you know, during the chat function, don't worry. We are going to be sending this out via email. I also want to say a special thank you to the Road Home Program MST Subcommittee for putting this training on. Thank you to Dr. Sheila Dugan, Dr. Vanessa Tyrone, Dr. Jocelyn Kressler, and LSW Miso Boser for presenting on today's training. It was well put on, and we do appreciate your guys' time.
Thank you, everyone.
All right, so make sure that everybody that's filling out the survey to select non-Rush employee if you are not an employee of Rush Universal Medical Center. And this is going to let you bypass the employee ID portion of the form. And then, Chris, if you want to answer some of these questions via the chat or get on and actually answer some of them, I would appreciate it as well.
Should we get emails from people about some of these tech issues in terms of completing CEUs? We can always put together like an email to send out with some of these things. So if you guys have questions and you don't get them answered today, let us know. We'll send something out.
Yes, if you could, if anybody that has questions regarding the CEUs, please just email me directly at the ashton_kroner@rush.edu. I'm going to put this in the chat. And then I'll make sure to get back to everybody as they're coming in. I don't want to take up too much of everybody's time on these one-offs. So just please email me, and I can work through any technical issues that we have along with our IT guy, Chris Miller, and I'm going to put his information on as well. So if you could go ahead and email both of us, I would appreciate it. And then I'll go ahead and post the link one more time. It looks like I'm getting some feedback on that. Again, this is all going to be getting sent out. All this is going to be getting sent out via the email as well with some directions. All right, thank you again for everybody in attendance. We do appreciate your time. We're going to go ahead and end the meeting now. Again, if you have any questions regarding the CEUs or you're having troubles, please email me directly. Otherwise, I hope you guys all enjoyed the presentation and have a good weekend.